Hey guys, this is Johnny from SoCal EMS, and today we're going to be going over Chapter 15, Shock and Resuscitation. So the objectives for this chapter are to define shock. We're going to discuss the etiologies of shock. We'll discuss the different types of shock, how our body responds to shock. We're going to discuss the emergency care of the shock patient. We'll define resuscitation. We're going to discuss DNR, or do not resuscitate. We'll speak about some terminology, discuss defibrillators, some cardiac rhythms, and what to do if our patient has return of spontaneous circulation. So when we think about shock, these are our patients who are pale, cool, clammy. They might be altered and can have a number of reasons causing this patient to be in shock. So by definition, shock is the inadequate perfusion of cells, tissues, and organs with oxygen and other nutrients, resulting in cell tissue and organ dysfunction. So in order for us to understand how we can have inadequate tissue perfusion or hypoperfusion, to have proper perfusion, we need these 5 things. So in order for the body to maintain proper perfusion, it has to be able to do these 5 things. So the patient must be breathing with an adequate concentration of oxygen. The oxygen has to be able to diffuse across the cell membrane. The oxygen has to then be able to get onto the red blood cells. The red blood cells have to have an adequate blood volume and pressure to move the oxygenated hemoglobin throughout the system. And then finally, the oxygen has to be able to diffuse off of the cell and into the body system. So shock has 3 main etiologies. We can either have inadequate pump function, inadequate vessel tone, or inadequate volume. If our patients are showing signs and symptoms of shock, it's generally because one of these 3 causes. So when I remember these 3 etiologies, I like to think of a pump, pipe, or fluid problem. The pump is my heart, the pipe is my vasculature, and the fluid is my blood. So when we first talk about inadequate pump function, this is going to be the heart. So with our inadequate pump function, something is happening to the heart, which is decreasing its ability to pump blood to the rest of the body. So it doesn't matter whether we have good oxygenation and good blood volume. If the heart isn't able to push the blood into our system and deliver it to our bodies, we're going to go into shock. We have our inadequate vessel tone. So when we talk about our vasculature or our vessels, this is going to be our pipe problems. Based off of our sympathetic and parasympathetic tones, our vasculature is either going to vasodilate or vasoconstrict depending on the needs of our body. This is what gives our body something called systemic vascular resistance. And depending on the diameter of our vasculature, it will either increase or decrease our blood pressure. So the pipe problem happens when we have a massive vasodilation in our system to where we have this relative hypovolemia. So we don't lose any of our blood volume. It's the fact that our pipes are too big. So this is an analogy that I like to use. Imagine that you're at your home and you have your garden hose plugged into your water spigot and you turn it on. You have good pressure there. Now imagine if we took a fire hose and we plugged it into the same spigot at your home and how much bigger that hose is. We still have the same amount of volume or same amount of water coming out of that spigot, but because the hose is so large, we're not going to have any pressure. Therefore, you have that vasodilation or that massive hose, which you have no pressure, so you're going to have no blood pressure. So that's going to be your pipe problem. And then we have our volume problem. So when we talk about inadequate volume, this is going to be your fluid problem. So your fluid problem can either be the loss of whole blood or plasma volume inside your body. And this can be caused by a number of reasons. You can have bleeding, vomiting, diarrhea, excess urination, or capillary permeability, possibly due to burns. So what happens here is if I don't have enough blood in my system, if I don't have enough fluid in my system, it doesn't matter how big or small my vessels are, it doesn't matter how strong my heart is, I'm not circulating enough volume inside my body, therefore it's going to drop my blood pressure. As far as the types of shock, we have 5 main types of shock. We have cardiogenic shock, obstructive shock, distributive shock, hypovolemic shock, and metabolic shock. So when we talk about these 5 different types of shocks, I want you guys to remember, is this a pump, pipe, or fluid problem? Cardiogenic shock happens when the heart is no longer able to pump blood effectively or contract efficiently. This can either be caused by myocardial infarction or heart failure. Typically, it's when greater than 40% of the left ventricle is infarcted or tissue has died due to a myocardial infarction, and the damage to the heart is so great that it decreases your stroke volume, your cardiac output, therefore it drops your systolic blood pressure, which leads to shock or hyperperfusion. Your obstructive shocks is a condition that obstructs forward blood flow. So this is going to be your pulmonary embolisms, your tension pneumothoraxes, and your cardiac tamponades. This is a pseudo pipe problem because it's obstructing the forward blood flow. So I want you guys to think that there's a clog in the pipes. So something has clogged our drains. With your distributive shock, what comes to mind for me is distribution. So imagine that you're at the Amazon warehouse and you're sending all of your packages out to the rest of the body. Well, there's going to be an issue with the roadway, which is preventing that distribution of your supplies. So with your distributive shock, this is a systemic vasodilation. There's a relative reduction in your volume, not because that we've lost any fluids, but because our vasculature is too large. This goes back to our garden hose, fire hose analogy. So I have the same amount of fluid coming from the spigot at my home, but the fire hose is too large to have any good pressure, so I'm going to have a low blood pressure. Your hypovolemic shock, there's 2 types of hypovolemic shock. You have a non-hemorrhagic hypovolemic shock, and you have a hemorrhagic hypovolemic shock. Your non-hemorrhagic hypovolemic shock is going to be due to a loss of fluid or a shift of fluid because increased cellular permeability. So this is going to be your patients who are dehydrated, who have been vomiting and have diarrhea for multiple days, or your burn patients. And then you also have your hemorrhagic hypovolemic shock. These are going to be primarily your trauma patients or your GI bleeds, where your patients are bleeding out and losing all of their fluid that way. And lastly, there's something called metabolic shock. This is a dysfunction in the ability for oxygen to diffuse onto the blood and be carried by the hemoglobin. This is more commonly either due to CO poisoning or cyanide poisoning. I just covered the 5 main types of shock, and now I'm going to spend a little bit of time going over a few other specific types of shock. The first one is going to be burn shock. With our burn shock, depending on the severity of the burns and how large the burns are, what happens is you have increased cellular permeability, which is causing fluid shift from inside of the cell to outside of the cell, or the interstitial space. So due to this fluid shift, this is going to be a non-hemorrhagic hypovolemic shock. So plasma and plasma proteins leak from the damaged capillaries, and that loss of fluid leads to edema, and that fluid shift can potentially cause drops in blood pressure. We typically don't see burn shock in the pre-hospital setting. This is a little bit later in the care of these patients, and that's why it's so important to give our burn patients lots of fluids throughout the process. So our anaphylactic shock is a type of distributive shock. So when our patient is exposed to an allergen or antigen, we have this mediated response with our IgE immunoglobulins, which is triggering our mast cells and a histamine response. Through this overreaction of our body, it's going to create a massive systemic vasodilation and increases our capillary permeability. So with that vasodilation, it's going to decrease our systemic vascular resistance. Therefore, it's going to drop our patient's blood pressures, which is going to potentially cause them to be shocky or go into shock or hypoperfusion. Epinephrine, or our EpiPens, is the medication of choice for your anaphylactic shocks to reverse that interaction of the vasodilation and bronchoconstriction. So septic shock is another type of distributive shock, and this is an exaggerated inflammatory response to an infection in the system. So these bacteria and toxins get into the bloodstream and infects the entire system and causes vasodilation, which will decrease your blood pressure. These patients are going to have an infection or fever of some sort. There's an extremely high morbidity rate with these patients. Some signs and symptoms you might see with these patients are shivers, fevers, they might feel cold, they can have general discomfort or pain, pale skins, they can be difficult to arouse, altered, or sleepy, they could have feelings of impending doom and shortness of breath. It's not uncommon for these patients to have a respiratory infection or UTI, which then progresses into sepsis. Neurogenic shock is also a distributive shock. What happens with our neurogenic shock if we have a spinal cord injury that damages or severs the spinal cord? We're no longer able to have that sympathetic nervous tone go past that injury. So our parasympathetic tone overtakes that, causing that vasodilation or those vessels to dilate. This increased parasympathetic tone, or this increased feed and breed, rest and digest tone, causes that vasodilation, which decreases our systemic vascular resistance. Therefore, we're dropping our blood pressure. With these neurogenic shock patients, it's not uncommon to see something called a line of demarcation, meaning that wherever the injury site is, above the injury site is still getting that sympathetic nervous tone. So it's going to show those signs and symptoms of shock. But below the injury site, you're not going to see those signs of shock because it's not getting that sympathetic tone beyond the injury site. Cardiogenic shock is when our heart fails as a pump. It's generally caused by acute myocardial infarction, congestive heart failure, or abnormal cardiac rhythms. We kind of talked about it a little bit earlier, but when that left ventricle fails as a pump, it's no longer adequately able to pump blood into the system. If we don't have a good cardiac output or a good stroke volume, it's going to decrease our blood pressure. Therefore, our patients are going to become hypotensive or in a hypoperfusive state. So how does our body respond or react to shock? At the moment of injury or insult, our sympathetic tone is stimulated immediately. Our fight or flight starts taking over. We have increased heart rate, increase of ventricular contraction, vasoconstriction, and our body's going to release epinephrine and norepinephrine from the adrenal glands. Once we're injured or hurt, or once our body realizes that we're going into shock, it's going to do everything that it can to reverse those by turning on our sympathetic nervous system or our fight or flight. Our epinephrine has alpha and beta effects that cause vasoconstriction and increase cardiac output, and our norepinephrine has alpha effects that strengthen that vasoconstriction as well. So as our body's trying to vasodilate, or as our body's dealing with either a pump, pipe, or fluid problem, it's going to release epinephrine and norepinephrine in order to help vasoconstrict to maintain that blood pressure. We have 3 different stages of shock. We have compensated shock, decompensated shock, and irreversible shock. With our compensated shock, this is our body's trying to compensate, or it's still able to maintain near normal blood pressure and perfusion to vital organs. Say we are injured immediately, our first reaction that our body does is going to increase that sympathetic nervous tone. So it's going to release the epinephrine and norepinephrine. We're going to have increased heart rate. We're going to have an initial spike in blood pressure, increased respiratory rate, and eventually our blood pressure is going to stabilize to a normal range. During this compensated shock stage, blood is shunted away from non-vital areas such as the skin and GI tract, and is trying to pull it all into our core to maintain blood flow and stability in our vital organs. As our body continues to compensate, when it's no longer able to compensate and they start failing, we go into decompensated shock. In decompensated shock, our compensatory mechanisms are overwhelmed and our body can no longer maintain our blood pressure and perfusion of our vital organs. We then transfer from aerobic metabolism to anaerobic metabolism. Our vital organs are no longer being perfused effectively, and we have decreased heart and brain perfusion, and our vital organs are no longer being perfused effectively. When I'm looking at vital signs with my decompensated shock, our biggest tell is our blood pressure drops. So if I have an increased heart rate and a decreased blood pressure, that's when I know that my patient is now in decompensated shock. And our number that we're looking for is less than 90 systolic. Our patient is now decompensating. And as our shock progresses, we have our final stage. We have something called irreversible shock. The damage is so severe that despite our treatments, death is usually inevitable. We have microemboli blocking capillaries, which is leading to multi-system organ failure, and our clotting factors are depleted. When I'm looking at vital signs for our irreversible shock, this is when our pulse finally drops, our blood pressure drops, and our respiratory rate drops. So to recap our stages of shock, with compensated shock, we have increased heart rate, increased blood pressure, which stabilizes to normal limits, and an increased respiratory rate. With our decompensated shock, we have increased heart rate, decreased blood pressure, so systolic blood pressure less than 90, and increased respiratory rate. And our irreversible shock is a decreased heart rate, decreased blood pressure, decreased respiratory rate. So as far as signs and symptoms of shock or signs of poor perfusion, one of the first things to go for our shock patients is their mental status. So if we have someone who has an altered mental status or is confused, it could be an early sign of shock. Sometimes anxiety can be an early sign of shock. We're going to have pale, cool, clammy skins, a cap refill greater than 2 seconds, or a delayed cap refill. They're going to have a decreased urinary output. That's less of a thing for us in the pre-hospital setting, but if we're doing an interfacility transport on a BLS unit or a CCT unit, it might behoove us to see what the urine output was. This is indicative of our kidney failure, and we have our weak or absent peripheral pulses. So if our patient has no radial pulse, no brachial pulse, and a weak carotid pulse, these are all signs of potential shock. As far as emergency care of our shock patients, we need to control any major bleeding and do any meaningful interventions at that time. We're going to establish and maintain their airway. We're going to ensure that we have oxygenation greater than 94%. We're going to assist ventilations with a BVM if necessary. We're going to place the patient supine and keep them warm and as calm as possible, and transport these patients to definitive care. With my shock patients, we have an acronym called CLOT. It stands for cover, lay supine, oxygenate, and transport. That is a good rule of thumb for treating our shock patients. The only thing not in CLOT is going to be control any major bleeding. So we can call it X-CLOT, or we can just call it CLOT and know that we have to stop any bleeds when we see them. So if our patients get sick enough, they can go into cardiac arrest, and then we would have to begin resuscitation. Resuscitation, by definition, is the act of bringing the patient back from a potential or apparent death, and cardiac arrest is when the ventricles of the heart are no longer contracting, or when the cardiac output is completely ineffective and no pulse can be felt. So with cardiac arrest meaning stopped or not working anymore, your heart is no longer working, therefore it's stopped, and you have no pulse. The pathophysiology of the cardiac arrest. There's 3 different phases that our bodies go through once our heart stops. We have the electrical phase, the circulatory phase, and the metabolic phase. The electrical phase is within the first 4 minutes of the code. Your heart and your body still has oxygen and glucose in the system, and if we can get our meaningful interventions or early CPR, conditions are favorable for resuscitation, and our heart responds really well to defibrillation at this time. The circulatory phase is going to be 4 to 10 minutes after your cardiac arrest. This is where your oxygen stores begin to become exhausted. We're running out of glucose in the system, and your anaerobic metabolism begins. So we're no longer creating ATP as efficiently as we should be during that aerobic metabolism. High quality CPR is needed in these cases to supply oxygen and glucose to the body. So we also have to remember that good quality CPR is the best way for us to ensure good outcomes for our patients. As the code progresses, or as our patient remains in cardiac arrest, we then go into the metabolic phase. This occurs 10 minutes after the cardiac arrest occurred. The heart muscle becomes acidic and ischemic, and tissue death begins to happen. At this time, beyond 10 minutes, without the high quality CPR, without our meaningful interventions, our brain resuscitation begins to become unfavorable. And if this patient is to come back from the arrest, the long-term outcomes are beginning to deteriorate. Withholding resuscitation. When do we or when can we not resuscitate our patients? We need to have something called a DNR, or a do not resuscitate. The do not resuscitate order can be in a number of forms. Some of the more common ones are going to be a DNR. So this is a form signed by a doctor stating that the patient does not want to be resuscitated. So no CPR. When their heart stops, we let them go. There's something called a PULSed form, or a physician's order for life-sustaining treatments. This is going to be an order from a physician based off the patient's request for any care that we can give them. So this might say something along the lines of do not intubate, but they want CPR, pain management, and it's a request of treatments if this patient were to code or if their heart were to stop. We also have something called a DPOA, durable power of attorney. With this form, it's stating that if this patient were to code or if their heart were to stop and they were to die, a next of kin can make medical decisions for them. So we also have our obvious signs of death. So we have our incineration, rigor mortis, we have evisceration of the heart or brain, we have decapitation and decomposition. And in some places, there's also lividity. So some cardiac arrest terminology is we have our downtime. So our downtime is from when the patient codes to the beginning of initial effective CPR. And then our total downtime is when our patient goes into cardiac arrest to the time that they get to the ER. So if our patient has a witness arrest at 10 o'clock and we have bystander CPR start at 10:04, the downtime would be 4 minutes. But if we have our witness arrest at 10 o'clock, we get on scene and we transport our patient and get them to the ER at 10:13, your total downtime is going to be 13 minutes. We have ROSC, which is return of spontaneous circulation. As we're doing CPR on our patients, if we get a return of a pulse, that is considered ROSC. We have witness versus unwitnessed arrest. Your witness arrest is if a bystander sees a patient actually collapse and codes, versus your unwitnessed is if a bystander is to just walk into a room and find someone who is down and in a code status. Your AHA chain of survival, you have activation of the emergency response system, we have high quality CPR, early defibrillation, advanced resuscitation, post-cardiac arrest care, and our recovery care in the hospitals in getting those patients back home. Our automatic external defibrillators, or our AEDs, are a device used to deliver electrical shock to our patients to convert a fibrillating heart to an organized rhythm with a pulse. There's two types of AEDs that you might see out there. There's something called monophasic and biphasic. Monophasic means that the electricity travels from one lead to the other through a single path. And then your biphasic means that you have electric currents going both ways from both electrical paths meeting into the center. The advantages of your AEDs are that they are easy to use, the speed of operation is high, they're efficient at monitoring the patient's rhythms, and they're safe and effective to deliver our defibrillations. We have semi-automated and fully automated defibrillators. So a semi-automated defibrillator, the operator has to turn on the AED and actually pushes the shock button, versus a fully automated AED is the operator will turn on the AED and then the AED analyzes and delivers shocks on its own. Regardless whether you're using a semi-automated or fully automated AED, it's extremely important for you to make sure that you are clear from the patient when it prompts you to, so you don't accidentally shock yourself or any of your partners or anyone around you. As far as AED pad placement, we have an anterior lateral placement, meaning that one goes on the top right of the patient's chest, right above their clavicle, and then the other one goes on that left mid-axillary line in that fifth intercostal space. And then we have our anterior posterior, which is most commonly used for our pediatric patients, where we place one on the front above the heart and on the back behind the heart. Your analysis of your cardiac rhythms. So the rhythms that your AEDs can shock are going to be ventricular fibrillation and your ventricular tachycardia. A couple of the other rhythms that we're going to go over are asystole and pulsus electroactivity, or PEA. So your ventricular fibrillation, or your VFib, this happens when your ventricles, or that lower portion of your heart, are fibrillating. This is a disorganized cardiac rhythm that produces no pulse and no cardiac output. So imagine that your heart is just kind of fibrillating, or all of those electrical conduction circuits down at the bottom are just firing off in no organized rhythm and no organized manner. We have our ventricular tachycardia. So the ventricle, still that bottom circuit, is firing off. It's a rapid heart rate that is generated in the ventricles, and due to how quickly the heart is moving and quivering, it has reduced cardiac output because there's no time for the ventricles to fill. This VTAC can eventually become VFib, and this is also a shockable rhythm. We have something called asystole. So every time that we're watching some medical show and they're in the ER and they're like, oh my gosh, they flatlined, and you just see that flat line straight across, that's asystole. Asystole means A without systole, electrical activity. So we're going to see that as a flat line. There's no pumping action, there's no electrical action going on in the heart, and this heart has stopped. Then we have something called PEA, or pulseless electrical activity. So in the heart, we have the electrical conduction circuit and we have the mechanical conduction circuit. Your PEA is when you're having some electrical activity that looks organized, but there's no mechanical side of the heart. So the heart's not pumping in any way, but the electrical circuit is still working. We do not defibrillate asystole or PEA. So as far as transporting our cardiac arrest patients, when do we transport these patients? Well, of course, if we regain ROSC, so if we have that return of spontaneous circulation, we're going to transport these patients. After our third defibrillation, or any time that we're doing CPR and we have 3 consecutive no-shock indicators, if our patient has a pulse or regains ROSC, we want to maintain their airway. We want to get a 12 lead, a blood pressure, a pulse, and respirations. We're going to oxygenate these patients and make sure you have suction ready. If they don't have a pulse during this code status, as always, we're going to continue high quality CPR throughout the entire transport. Our cardiac arrest in our pregnant patients. So if you do have a patient who is pregnant, and this is generally patients who are greater than 20 weeks pregnant, we're going to have to manually displace the baby off of the mother's vena cava. So with our pregnant patients, if they lie supine, they can go into supine hypotensive syndrome, meaning that the baby's compressing the vena cava, which is decreasing that preload to the heart, which is then decreasing the afterload to the body. So for us to do high quality CPR, we have to lay these patients flat. So you're going to have to delegate to a rescuer to displace the baby to the left side of the patient's body to get that baby off of the vena cava. So as we're doing high quality CPR, we can help increase that blood flow. Your cardiac pacemakers, there's a couple different types. Your pacemaker, so if we think about our heart and the electrical conduction side of the heart, We have our SA node, which is our primary pacemaker of the heart. This is what's going to maintain our heart rates between 60 and 100. If our SA node becomes ineffective or the electrical conduction circuit system of our heart decreases, we can have surgically implanted pacemakers, which are a device which takes over for our SA node to maintain those good heart rates. There's also something called an automatic internal cardioverter defibrillator. If we have patients who are susceptible to going into those VFibs and VTACs, they can have a miniature defibrillator placed in addition to a pacemaker, which if their heart goes into one of those shockable rhythms, it can defibrillate it immediately. We have automated CPR devices. There's a number on the market. We have something called AutoPulse. There's a DefibTech Lifeline arm. There's also a Lucas device. These are great devices if used properly. It increases the opportunity to gain ROS. You have high quality CPR that's consistent the entire time. It's freeing up rescuers' hands, and we can have good quality CPR on these patients, whether we're in the back of an ambulance or moving them downstairs or in a cramped back bedroom. So that's going to conclude our chapter 15, shock and resuscitation. So just in conclusion, we've defined shock, we've discussed the etiologies of shock, we've talked about the different types of shock, how our body responds to shock, we've discussed emergency care of shock patients, we've defined resuscitation, defined DNRs, talked about some terminology, talked about defibrillation, some cardiac rhythms, our VFib VTACs, which are shockable rhythms, and then ROSC and how to treat our patients who have coded. As always, thanks for tuning in, and I'll see you guys next time.